If you have ever been told that you have osteoporosis, then the next sentence in that office visit is probably something like, you need to start a medication for your bone health. And for a lot of people, that is where fear begins, because people start Googling stuff and they see stuff like Fosamax causes jaw problems or Prolia causes rebound fractures. And these drugs can stay in your bones forever and ever. So today what I want to do is just slow down all the Googling, all the chat GPTing, and actually explain osteoporosis medications, what they do, how they work, why doctors prescribe them, and really talk about the benefits and the risk in a realistic way that hopefully helps you feel a little bit more comfortable with it. So if you or anyone you know are taking any medications for osteoporosis, this video is for you, or please send it to them. If you are new to my channel, my name is Dr. Takova Wallace-Gay. I am a board-certified primary care pharmacist, and I'm also an associate professor of medicine where I teach medical students all about the drugs. On this channel, my role and my hope is to help people understand their medications in plain language. I'm very passionate about medication understanding, and I want people to be able to ask better questions, feel confident about their treatment decisions, and take medications safely. So today we are going to talk about osteoporosis medications, the science behind them, how they are used, and really some of the most common concerns that patients have. So let's get into making this make sense. And first, we need to talk about what osteoporosis actually is. It's important for you to know that your bones are not static. Your skeleton, your bones are constantly remodeling through two major types of cells in your body. One are osteoclasts, they break down bone. And two are osteoblasts, they build up bones. Osteoclasts, that's your cleanup crew. They clean up the bone, they break it down. Your osteoblasts build up the bone. Now, normally this process is balanced. Like a lot of other things in our body, we have this kind of homeostasis where things are balanced. But with aging, with certain risk factors, and especially after menopause, when estrogen levels drop, bone breakdown begins to really outpace bone rebuilding. And so over time, that can lead to lower bone density and weaker bones. And what that does is increase your risk of having fractures. And the most common fractures we worry about in osteoporosis are hip fractures and vertebral compression fractures in the spine. We also worry about wrist fractures as well. So according to the National Osteoporosis Foundation, about 10 million Americans have osteoporosis, and many, many more people have what we call low bone density. The reason doctors treat osteoporosis is really simple. We're trying to prevent fractures because once a fracture occurs, especially a hip fracture, the risk of disability, the loss of independence, the prognosis overall for a person is poor, and just all these risks just increase significantly. So our goal is really to reduce the risk or prevent fractures. Now, just to be clear, not every single person with bone thinning or bone reduction needs medication. So your physician, your prescribers are going to look at a few different factors. One is going to be your bone density, and we can look at that from something called a DEXA scan. So they'll look at your numbers, determine what that is, and that helps inform them of whether or not you might need a medication. We also look at your history of fractures. Have you ever had a wrist or hip or ankle or any other fracture in the past? And then we also calculate a FRAX score, FRAX, which is your risk of having a fracture long-term. Now, this is an online calculator. You can look up your own FRAX score. I'll put the link in the description box below. But you can put in all that information and calculate that yourself. But just make sure you talk to your practitioner about how to use and interpret that number. And so overall, looking at all those things, if your fracture risk is high enough, then medications may be recommended to protect the bone. Now, most osteoporosis medications fall into two main categories. The first group slows down bone breakdown. These are called anti-resorptive medications. So they slow the breakdown of bone. The second group actually help build up new bone. And so really, before we get into the prescription medications, I want to take a note here and say that regardless of if you're on medications, or if you're not on medication yet, you need to also be on calcium and vitamin D. So you need to be taking around 2,000 units of vitamin D per day. the guidelines will recommend somewhere around 600 to 800, but a lot of times you can go over the counter and get a 2,000 unit little capsule of vitamin D. You just need to be getting vitamin D at least 600. Most practitioners will say optimally 800, but you can even push that to up to 2,000. And then you also need to be on calcium. So you need to be getting around 1,200 milligrams of calcium every day. But calcium is tricky because your body can only use and absorb so much of it at one time. And so if you see that you have a calcium supplement, let's just say calcium carbonate, and it's a 600 milligram tablet, well, the dose is going to be 2 tablets to get your 1,200 milligrams for the day, but you need to take one of those in the morning and one of those 4-6 hours later or more. Again, just to give your body time to actually absorb that calcium and get it in. And then you're also getting calcium from your diet. You're also getting vitamin D from the environment and from your diet. So those things count as well. But we really want to make sure that you're getting consistent intake of calcium and vitamin D, because those things are going to really help support bone health overall. Now, it also gets tricky because you have to be cautious about which type of calcium that you get. And I can go into a whole other video just about calcium supplementation. But some of them interact with medications. Other versions, like calcium citrate, don't interact with medications very much, but they still can, just not as much. And so those are questions that you need to be talking to your provider about. Which type of calcium do I get? How do I dose it? And then how do I dose the vitamin D with that as well? All right, now let's get into the medication. So the most prescribed prescription medication for osteoporosis are called bisphosphonates. Some example bisphosphonates are things like alendronate, which is the brand name Fosamax, zoledronic, which is the brand name Actonel, abandronate or ibandronate, which is the brand name Boniva, and then we have zoledronic acid, which is the brand name Reclast. Now, these medications are usually going to be your first line for osteoporosis, and doctors are going to go to those first. They're easy to take, they're quick, and they're not very expensive. So let's talk about how they work. Bisphosphonates specifically bind very tightly to the mineral surface of your bone, specifically to structures called hydroxyapatite crystals. You don't have to remember that, but just know that they bind very tightly to this mineral surface of the bone. Now, when osteoclasts are breaking bone down, they ingest the bisphosphonates along the way because they're on top of that bone. So they're ingesting the bisphosphonate as well because it's deposited into that bone. Inside the osteoclast, this drug is going to interfere with a very important pathway. And because it's interfering with that pathway, and more specifically, blocking a certain protein in that pathway, it disrupts the osteoclast function and eventually causes these osteoclasts to die. So they have kind of this programmed cell death. So you've got the bisphosphonates deposited onto the bone. The osteoclasts come along to clean up or break down that bone. The drug then gets deposited into the osteoclast and kills it from the inside. So again, bisphosphonates slow the cells that break down the bone. And this shift is going to allow the bone building cells to now outperform the bone breakdown cells. So now your osteoblasts have a little bit of an advantage over osteoclasts because we're basically killing off some of the osteoclasts. Now, one of the interesting farm points about bisphosphonates is that they have a really, really, really low availability, what we call bioavailability, which means when you take any pill by mouth, only so much of it gets into your bloodstream because you've got to go through the gut and through the liver and all these different processes that, interfere with that drug along the pathway to getting to where it needs to go. So bisphosphonates have a really, really low bioavailability. In fact, it's about 1%, or some references will say less than 1% of the medication is absorbed from the stomach. So most of that drug is going to be, excreted or removed from your body by the kidneys. But the portion that binds to the bone just stays and stays for years and years and years. 5 to 10 years, this drug can stay deposited onto the bone. So that long skeletal residence time, it just kind of like moves in and sets up shop. This is why you can sometimes hear about something called a drug holiday with bisphosphonates, because after several years of treatment, sometimes around 5 years, some patients that have improved bone density and have lowered their fracture risk may pause therapy. And we're still going to see benefits from the drug because it is deposited into the bone for such a long time. So the decision to take a drug holiday is very individualized. Again, it depends on your risk profile, conversation with your practitioner, but just know that that is a very common thing to see. Now, one of the most common questions I feel like patients ask is, how do we take it? And it's also one of the most common things that we teach our students to talk to patients about, even if they don't ask it. Because for medications like the oral bisphosphonates, which is like alendronate, Actonel, these medications are very specific on how they need to be taken because, as I mentioned, they already don't have a really high bioavailability. So if you don't take them the right way, then you're further reducing their bioavailability, which means that just less of the drug is getting to where it needs to be. So they specifically should be taken first thing in the morning on an empty stomach with a full glass, 8 ounces of plain tap water. And after taking the medication, the patient should sit upright for at least 30 minutes. This is going to, one, help with the absorption of the medication and distribution throughout the body, but also it's going to help with reducing GI upset, dyspepsia that can occur with the medications as well. And you also just want to avoid eating during that time. So for that full 30-minute time frame or so, you want to avoid eating as well. All right, let's talk about some side effects with these medications. Some common side effects include stomach irritation and reflux. And sometimes we can see muscle and joint aches with them as well. But overall, most people do pretty well on these medications and don't have a lot of issues with it. Two of the rare but very serious side effects that people are concerned about are something called osteonecrosis of the jaw and something called atypical femur fractions. Now, the osteonecrosis of the jaw just means that that bone starts to die. And dentists are really concerned about this, but your primary care provider will be concerned about it as well. And so they'll give you some things to look out for. But again, very rare. And then also atypical femur fracture. So fracture in one of your leg bones can occur. Again, generally not that common, especially with bisphosphonates. It's more common with another drug that we'll talk about in a second. But just know that that's just something to watch out for. Although they sound really scary, they happen really, really rarely. I've never seen one in a patient since I've been practicing, but you just want to make sure that you're cognizant of your side effects and how your body is feeling, and make sure that if you do feel a little bit off, any bone pain, that you talk to your provider about that. Now, let's move on to another major osteoporosis medication. This is a drug called denosumab. The brand name for denosumab is Prolia. This medication works very differently from the bisphosphonates. Denosumab is what we call a monoclonal antibody, which means that it essentially targets a molecule in the body, and that molecule is called RANK or RANK ligand. So it targets that particular molecule. And the thing that's important to know about RANK or RANKL is that it is required to activate osteoclasts. So we talked about osteoclasts that break down the bone, but in order for osteoclasts to even get the job done, they have to be activated by an outside force. And so RANKL is that outside force that activates osteoclasts. So by binding to RANKL, denosumab is going to prevent osteoclast formation and thus prevent their activity. So this means that bone breakdown is going to be reduced. So the output for bisphosphonates and for denosumab is the same. We're reducing osteoclastic activity, but the activity of these osteoclasts, but the bisphosphonates are doing so in a different way than denosumab. Denosumab is just preventing osteoclasts from being formed, whereas bisphosphonates are depositing on the bone, getting into the osteoclast and killing them from the inside. So let's talk a little bit more about denosumab, otherwise known as Prolia. This medication is given as a subcutaneous injection, that means under the skin, every 6 months. One very important clinical note with Prolia is that doses should not be missed or significantly delayed. If the medication is stopped without transitioning to something else, then you can see rapid bone loss occur. And in some cases, you'll see rebound vertebral fractures, and that has been reported. So for this reason, denosumab used to be a first-line therapy. And in the newer guidelines or guidance that we look at for treating patients, denosumab is now a second-line therapy. Some of your providers will still use it as first line. It works really well. But if for some reason you or your provider do not feel that you can adhere to the consistency of coming in, pretty much on the money every 6 months, then this may not be the drug for you. So again, if someone starts Prolia, their care team will usually kind of plan ahead for what that long-term strategy will be and when you might need to transition to a different drug if that ends up being the case. All right, so those are the medications that work on osteoclasts. So they prevent bone breakdown. Now let's talk about the medications that actually help build up new bone. These are typically used in patients with more severe osteoporosis or individuals who have a very high fracture risk. So some examples here include teriparatide. The brand name for that is Forteo. And then we have abaloparatide. And then we have romosozumab, and its brand name is Avinity. Now, let's talk about teriparatide and abaloparatide first, because these are similar. They are analogs, or they kind of mimic a hormone that we already have in our body, which is the parathyroid hormone. And so when we give it intermittently, on and off, they stimulate osteoblast activity and promote new bone formation. So they're essentially helping promote something that our body would normally do, but is not doing as well. And so we can give that to help stimulate those osteoblasts to do their job more efficiently and effectively. Now, romosozumab is a little bit different. It blocks a protein in the body called sclerostin. Now, sclerostin normally inhibits bone formation, but if we block sclerostin from doing its thing, then now we have increased bone formation, and also it decreases bone cleanup or bone breakdown. So those are both very good things that we're looking for in these drugs. These medications are usually prescribed for very limited durations just because they're not easy to use long-term. They're a little bit more manipulative on the hormones in the body. And so we'll give them for a period of time for high-risk patients and then follow it up with an anti-resorptive medication like a bisphosphonate. Another important piece of treatment, again, is just to make sure that you are getting all your adequate nutrients, especially the vitamin D and calcium, but also incorporating other nutrient-dense foods as well, and incorporating physical activity, so weight-bearing exercises, being aware of your surroundings, so rugs, cords, and just reducing your fall risk because of things being in the way. So all those things have to be taken into account when we are bringing patients in and talking to them about medications. Now, one of the biggest misconceptions that I hear is patients refusing treatment because they're afraid of the medications. And I completely get that. Not too long ago, there was a patient who had a friend that was on a bisphosphonate, and her friend had really bad reflux because of it. And she just did not want to take it. And so, just having that conversation, talking to her about how to take it and just telling her to maybe try it. And then if she didn't like it, we could switch her to something else. But because this was cheap and worked really well, it just made the most sense to go there first. So I think you always have to balance the risk of something, like the risk of the medication versus the risk of having a fracture. And then also think about your lifestyle and what things are going to fit well with that. We know that in patients with untreated osteoporosis, their fracture risk significantly increases. And so we really do want to try to prevent that, but we also don't want you to take a medication blindly. Like, you really need to understand how the medications work and why you're taking it. And that way you can have more informed conversations with not only your healthcare team, but also your family and anybody else. So hopefully this video was helpful, helped you understand osteoporosis medications a little bit better. Please subscribe to my channel and let me know in the comments which medication topic you'd like to see explained next. Thank you.